All right. What is up? Okay. Will you guys tell me if this is big enough for you guys to see? For the last time ever. Can you see this all right, user? Is it big enough? Okay, cool. All right, let's wait a few minutes, see if we can get a little bit of a crowd, and then we'll jump in. So today we are going over, for the last time in January, we are going to go over musculoskeletal, neuro, and cardiovascular or cardiopulmonary content. So how has your guys' studying been going this last week? I hope you guys are making plans to not study tomorrow or Tuesday based on when your test is, because you really need the break. And if you haven't learned it by tomorrow or Tuesday, or if you haven't learned it by now, you probably won't learn it tomorrow or Tuesday. That's the general rule that we go by. But user, I saw going, and I'm done probably by 7 p.m. ish. Yeah. Your test scores that you sent me, I thought looked really good, and I mean, you're gonna be. I think I told you this, but you're gonna be nervous because it's the biggest test of your life. But those test scores are solid. There was only like one section where you didn't get at or above what they said you needed to be on track to pass, and you had enough right answers in other sections that it was like making up for the one spot that you didn't, that you only missed by like one question. And so I think you're gonna do fine. I wouldn't be too worried about it. You seem like you know what you're doing, and it's just a matter of taking your time during that test, making sure you don't misread or make any silly mistakes. I also recognize that there's a lot of snow. Of course, dude. There's a lot of snow going on. And so I kind of expect we may have a smaller audience tonight than normal, but hopefully we'll get Dr. Trent in here and our other regulars, and then we can get started. You're in this time zone? Like you're in my time zone? Okay, let's go over it. All right, so I have a super long explanation to this question. Oh, Eastern. Super long explanation on this one. This was just in case questions come up and I needed a way to like remember my notes. And so a patient with knee OA demonstrates decreased knee flexion during loading response in gait. This deviation most likely results in A, decreased shock absorption, B, increased quadriceps demand, C, decreased joint compression forces, or D, reduced ground reaction forces. That's why I'm always wanting to finish. Well, I knew you were on the Eastern time zone. I didn't know where on the Eastern time zone. I didn't know if Florida was somewhere different than normal for you. If you guys have people taking the test this week, taking your NPTE this week, don't be afraid to share my live with them so that way they can be on for our last MSK Neuro and Cardiopulmonary review. I will be taking a break over the next couple of weeks since we will just be finishing up with this January boards exam this week, and then I will spend some time writing some new content, trying to make some more videos that I can post throughout the week, and then I'll start back probably halfway, second or third week of February, I guess. But let me read through this one more time. A patient with knee OA demonstrates decreased knee flexion during loading response in gait. This deviation most likely results in A. Increased shock absorption, B. Increased quadriceps demand, C. Decreased joint compression forces, or D. Reduced ground reaction forces. You guys go ahead and answer what you think is the right answer. I'm a big proponent of engaging with the material even if you don't know it, because when you submit an answer, when you actively respond to something, it's actively participating in your learning experience, and that means that it's going to stick better in your brain than if you're just being passive about learning. So if you're actually interacting with it, your brain is going to engage with it in a way that makes you learn it better. I'm a second-year PT student from the Philippines, and I failed my prereq subjects. How do I cope? I don't know. I'm not 100% sure what you mean, buddy, just because I never had anything that we called prerequisite subjects. I mean, I think if you buckle down and just figure out where you went wrong, I think there's always hope, right? You just, the amount of effort you have to put in, maybe more than what you would, normally want to, but neither here nor there when it comes to studying for the NPTE right now. So let's go ahead and go over the answer. Okay, so let's go over this first section. The answer is B, increased quadriceps demand. So reduced knee flexion requires quadriceps to eccentrically control the limb, increasing demand and joint stress. Shock absorption, so A is wrong because shock absorption would be decreased, not increased. The reason that is because if you have a stiffer knee and you land, I could see how that's the answer. If you stiffen how you land, when you land during loading response, you're going to put more of that impact through your knee. Whenever you have more knee flexion, all of that energy is able to be absorbed by your quads contracting eccentrically, and it's able to help reallocate that force to go forward in your momentum. So when we walk, and this actually happens a lot, right? Because we have some guarding with knee OA because it's painful, that people tend to walk more stiffly, and that's actually going to lead to worsened knee pain, because what's going to happen is that the tissues that are going to absorb that are going to be, I've got it in here somewhere, it's going to be your articular surfaces, basically. With less knee flexion, the limb becomes more rigid and forces are absorbed over less time. This leads to higher peak force. With decreased knee flexion, quads can't eccentrically absorb energy effectively, and energy is transferred directly to articular cartilage, subchondral bone, and joint surfaces. Joint compression actually increases, not decreases, and ground reaction forces are not reduced. Peak ground reaction force increases, and the rate of loading response increases because force is applied over less time. So your ground reaction force curve becomes taller, narrower, and has a steeper initial slope, i.e. increased loading rate, which is associated with OA progression, stress fractures, and joint degeneration. I do want to talk a little bit more about the ground reaction forces here, because I think this gives you a good analogy of kind of what we're looking at. So why is quad demand greater in less, like a smaller angle of knee flexion as opposed to a greater angle of knee flexion? Because I think this could get confusing. Obviously, at greater angles, we usually think that our muscles have to contract eccentrically with greater force to stabilize the knee. But what happens here is when you step and you have reduced knee flexion in loading response, your external moment gets larger, right? So in normal knee flexion, imagine that you're holding a door closed, and someone is trying to push open the door, but they're pushing from the side where the hinges are. They're going to have to produce a lot of force relative to you only having to produce a little force to keep that door closed, right? So that's similar with normal knee flexion during loading response, you have less force trying to cause knee buckling, and so the quads don't have to contract with as great of a force to prevent knee buckling. But let me just read. You don't have to work hard to keep the door closed because of the small moment arm between the joint, or the hinges, and where the force is being applied to open the door. With normal knee flexion, the ground reaction force is passing posteriorly to the knee, but relative to less knee flexion, the moment is smaller. With decreased knee flexion, the ground reaction force passes farther posterior to the knee joint and increases the moment arm of the ground reaction force. So because that moment arm increases, your quads have to contract even more forcefully to stabilize your knee. And so, and it's over less time with less mechanical advantage. So that's why the answer is D. That's the longest explanation I'm going to have tonight. But as I wrote this question, I just wanted to make sure it was really clear why the answer was B. Okay, go to number 2. A 67-year-old patient with a right hemisphere stroke demonstrates the following during therapy. Intact strength in the left extremities, consistently collides with objects on the left side, eats only food on the right side of the plate, and denies that anything is wrong. Which impairment best explains these findings? A, left homonymous hemianopsia, B, left unilateral neglect, C, constructional apraxia, or D, impaired spatial memory. You guys go ahead and answer, and we will go over the right answers in just a second. I'm going to go ahead and read it one more time. A 67-year-old patient with a right hemisphere stroke demonstrates the following during therapy. Intact strength in the left extremities, consistently collides with objects on the left side, eats only the food on the right side of the plate, and denies that anything is wrong. Which impairment best explains these findings? A, left homonymous hemianopsia, B, left unilateral neglect, C, constructional apraxia, or D, impaired spatial memory. Okay, very good, guys. So let's talk about why the answer is B and not A. So with right parietal lobe damage, which is what we're assuming is happening here, you get impaired awareness of the left side and also the left environment. So not just the left side of your body, but the whole left side of your environment, right? And so A, with a visual field loss, the patients might be running into things on the left, but they're going to know that something is off, right? So right parietal lobe damage leads to lack of awareness of your deficits. And so if a patient has left homonymous hemianopsia, they might have an issue with colliding with objects on the left side. And they also might have an issue with seeing all the food on their plate, but they are going to be aware that something is wrong with them. Whereas these people with left unilateral neglect don't. They have no understanding that there's anything wrong with the left, that's even their left side of their body. They just don't look that way. C would present as difficulty drawing or building, not spatial awareness loss, and D would not explain denial of impairment. So if they had impaired spatial memory, they may have issues with eating food on the left side of their plate, but that wouldn't explain why they are denying that an impairment exists. So that answer is B. Okay, let's go to our cardio poem question here. A patient with chronic heart failure reports dyspnea after walking 100 feet. During ambulation training, heart rate goes from 92 to 104, blood pressure goes from 118/72 to 120/70, and SpO2 goes from 95 to 94%. RPE is reported to be 15. What is the most appropriate action? A, continue at current intensity, B, increase walking distance, C, terminate exercise immediately, or D, reduce intensity lightly. We got user already answered. You guys go ahead and jump in and answer. Engaging with the material is going to make it easier for you to remember, especially if you get it wrong. But if you get it right, that just shows that you guys know what you're talking about, right? And I want this place to be a place where you guys can flex those brains and show how much you know, right? So feel free to submit your answer, and we'll talk about it here in just a second. Okay, let's go over it. So the answer is D, just like you said, user. An RPE of 15 is on this. If you can remember what that Borg scale looks like, 15 is under the section that is hard, right? And so our goal in a lot of our patients, but certainly our cardiovascular patients, is to try to have them between 11 and 13, right? So that like moderate intensity. The vitals are stable, so there's no reason that we need to terminate exercise, right? So C is totally out. A, too high perceived exertion, right? To continue at the current intensity, their exertion rate is too high, or their perceived exertion rate is too high. B would be unsafe, right? Just because they're already at a 15, and if you just force them to walk even further, then we might get to a point where we're getting a cardiac event. And so we just want to decrease the intensity a little bit. And then D, sorry, that should say C. C, no red flags. So we don't need to terminate exercise. All right, moving on to number 4. A soccer player reports knee instability during cutting movements. Lachman test is positive. Which muscle group best compensates for this injury? A, quadriceps, B, gastrocnemius, C, hamstrings, or D, popliteus? Go ahead and submit your answer choices. I'll read it one more time. A soccer player reports knee instability during cutting movements. Lachman test is positive. Which muscle group best compensates for this injury? A, quadriceps, B, gastrocnemius, C, hamstrings, or D, popliteus? Gentry, it's good to see you, girl. We're only on number 4, and I obviously, you have probably heard me say this by now, but I will post these to my YouTube channel after the fact, so you can see what the first 3 were if you want to. So let's go ahead. I'm going to give you a second, Gentry, to just be able to see the question if you hadn't gotten to see it, and then we'll go over the answer real quick. Okay. All right, so the answer is C. User, you were right. Oh, dang. So that's not a bad answer, Gentry. I'll tell you why. Okay, good. You mean C. Okay, let me tell you why. So hamstrings are going to resist anterior tibial translation, compensating for ACL deficiency, because the ACL's whole job is to prevent anterior translation of the tibia, right? And so when we lose ACL, we don't have that control, and we can get that slip anteriorly. That's what causes a positive Lachman, right? But hamstrings, because they're located posteriorly and their whole job is to flex the knee, right? They're going to pull that tibia posteriorly, and so they can give dynamic stability when we've lost static stability through the ACL. Quadriceps are going to increase anterior translation, so it's definitely not that. Gastroc can increase stability, so it's not a bad answer. It's just that hamstrings is a better answer because it's going to be more effective, predominantly because you're getting it proximally. Also, hamstrings is a much larger muscle, and popliteus only assists in unlocking. So popliteus is the one that does the screw home mechanism, right? All right, let's do another neuro question. A patient following a TBI is able to follow single-step commands but becomes agitated and confused during multi-step functional tasks. The patient requires frequent redirection and demonstrates decreased safety awareness. This presentation is most consistent with which Rancho level? A, level 7, automatic appropriate. B, level 4, confused agitated. C, level 5, confused inappropriate. Or D, level 6, confused appropriate. Give you guys some time to answer. Gentry, are you taking the boards this week, dude? I know that Trent and user 1543278 are taking it Tuesday, I think. Not Tuesday, then Wednesday, but I'm scheduled for April. Gotcha. Okay, so this will apply to you. I'm going to take the next couple of weeks off. You probably heard me say that at last live, just so I have time to like create content, and then I will start again like the second or third week of February, whichever one is 2 weeks from now. Or I'll skip 2 weeks and start again on that third week. But okay, let's go over the answer. The answer is C. They follow simple commands, they're easily distracted, they have poor carryover, but they're not agitated constantly. And that is a feature of level 4, is almost like constant agitation, and kind of the inability to follow even simple commands, right? So level 6, they would have goal-directed behavior with cues, which is just describing something too advanced compared to what we were given in the question. And then level 7 is independent with routine tasks, and so that's why. Wait till January, people get their boards. Wait till January, people get their boards exam results. Do you know how the snowstorm might affect score reporting? I don't expect it'll affect it at all, because all of that happens in an office, right? And so, unless they send you an email saying that score reporting will be delayed, but if they don't contact you saying that, then I wouldn't expect it to be delayed. I guess I could do that, huh? So that way you guys, I could work through the next couple weeks and then take a couple weeks in February off. I could do that just so you guys can hop in and tell me if you guys passed or not, which would be nice to be able to hear from you guys. Okay, let's move on to number 6. A patient post-CABG, post-op day 3, prevents with diminished breath sounds at bilateral lung bases and shallow breathing. Which intervention is most appropriate? A, manual percussion, B, incentive spirometry, C, Trendelenburg positioning, or D, diaphragmatic strengthening exercises. Let you guys answer. I do think it's more easy to learn when you guys respond, and so we get B. Just for your guys' learning sake and being able to process through the answer choices. So we got a few. Let's just go ahead. I'm not sure that the rest of you are feeling confident in answering yet, but maybe we'll build up your confidence and you'll realize that you know more than you think you do. Okay, the answer is B, incentive spirometry. Why? So this person is post-op CABG. They've got diminished breath sounds at bilateral lung bases and shallow breathing. So one thing we have to be worried about is atelectasis, right? Post-op, we don't want them to end up getting a collapsed lung. So we need to encourage deep breathing. So that way we make sure that we're maintaining those good inflated lungs. I appreciate this being on Sunday evenings. I can call it active studying. Yeah, well, I mean, I hope that's beneficial, especially just in preparation for the week, right? So, A is not going to be our first line of defense. Now, if they tried incentive spirometry, because incentive spirometers are something that they'll probably get anyway, right, while they're recovering in their hospital room. Whereas manual percussion, like if incentive spirometry is not working in terms of getting any stuff out of the bases of the lungs, then they might try manual percussion. Trendelenburg positioning is actually contraindicated post-cardiac surgeries, just because you don't want to overload the heart, right? And D, that's not an acute priority because we don't know for sure that diaphragmatic weakness is what's leading to the shallow breathing. And so, not necessary. Okay, moving on to another MSK question. The patient with adhesive capsulitis presents in the freezing stage. Which finding is most expected? A, severe stiffness without pain. B, limited active range of motion only. C, pain only at end range. Or D, global range of motion loss with significant pain. This question is really just asking you to know, in the very first stage of adhesive capsulitis, what predominates, range of motion loss or pain, and, well, I should say structural range of motion loss or range of motion loss due to pain. And then what you expect to see actively versus passively. And so I've got a couple people that have answered. We'll go ahead and go through the answer. This might be the quickest we've ever made it through these questions. But this is a much smaller audience than I've had in the past. I expect that. My students at the university here in Fayetteville don't have class tomorrow, so I imagine many of them don't feel like they need to be on top of studying. So maybe they are just chilling, drinking, playing video games. I don't know. So the answer is D. When we're in the freezing stage, we get pain and progressive loss of motion. Now, in the freezing stage, that range of motion loss is due to the incredible amount of must be ice. I wouldn't know. I am not a student anymore. So progressive range of motion loss in the freezing stage, that range of motion loss is due to the pain. And it doesn't matter if it's active range of motion or passive range of motion, pain is going to limit the range of motion regardless. A, severe stiffness without pain, that's describing the frozen stage, right? B, in the freezing stage, active and passive would be limited, like I just said. And then C is describing the thawing stage. So they only get pain at end range. It's probably more related to the intense stretch that they get on that capsule, right? Okay, number 8. A patient with incomplete SCI presents with the following: preservation of proprioception bilaterally, loss of pain and temperature beginning 2 segments below the lesion, and motor weakness below the level of injury. Which syndrome is most likely? A, Brown-Séquard syndrome, B, central cord syndrome, C, anterior cord syndrome, or D, posterior cord syndrome. This one is just knowing the map of the cross-section of the spinal cord, right, and where each major tract that we're looking at in diagnosing spinal cord injury is. So, okay, I got a couple people that have answered. We will wait just a little longer so user can send his answer in at least. Okay, you guys are right. Way to go, anterior cord syndrome. The reason being, right, the thing that should definitely clue you into anterior cord syndrome, if you know the map of that cross section, right, we know that DCML sits as far posteriorly as you can get, right? And so if the DCML is responsible for proprioception, if you get proprioceptive preservation with a spinal cord injury, then it's got to be anterior cord syndrome, right? Because everything else on this list would hit it somehow. Brown-Séquard is an infarct or a lesion of the hemisection of the spinal cord, so at least half of the body would have probably proprioceptive and light touch deficits. Central cord syndrome is going to be more motor loss in your upper extremities than your lower extremities, but it's still going to take out part of your DCML. Posterior cord syndrome is most likely due to a posterior spinal artery stroke, and it's only going to lead you with DCML deficits. So, number 9, cardiopulmonary. Oops. Gosh dang it, Austin. We're going to move on, and I'll come back to it. Maybe you guys will have forgotten. Number 10, a runner presents with medial tibial stress syndrome. Upon clinical examination, the patient reports pain along the medial tibial border that is diffuse. She also reports that her pain improves after warming up. Which factor most directly contributes to this? I'll move back up to it and just, okay, well, I'll move back up to it after this one. But let's go ahead and jump into this MSK one. I'll read it one more time. A runner presents with medial tibial stress syndrome. Upon clinical examination, the patient reports pain along the medial tibial border that is diffuse. She also reports that her pain improves after warming up. Which factor most directly contributes? A, high arched foot, B, excessive pronation, C, forefoot varus, or D, limited hip internal rotation? Let you guys have a little bit of time to read through it again if you need, think about it, and then submit your answer. Obviously, some of this stuff is just reinforcing that diagnosis of the medial tibial stress syndrome, right? So things like diffuse pain, right, along the medial tibial border, and that her pain improved after warming up. Not familiar with this condition. Shin splints. So medial tibial stress syndrome is just a fancy way to say shin splints. So let's go to the answer, if you guys. Okay, yeah, let's go ahead and go to the answer. So the answer is B, and let's talk about why. So excessive pronation increases tibial stress through traction forces on the bone periosteum. And so if you have a significantly pronated foot, every time you land, it's going to cause a pull on the periosteum that attaches to the medial tibia, and that's what's going to create that shin splint pain. High arches are more likely to contribute to stress fractures. Now, people, you can get MTSS with foot rigidity, but because that rigidity is more likely to cause a lot of increased um, impact through your foot, you're more likely to develop stress fractures because you don't have enough absorption into the bone. In the acute stage, you might get MTSS with high arches, but like I said, it's more likely going to develop a stress fracture, which is going to be more focal pain that doesn't go away after warming up. In fact, it gets worse the more and more you do. So, let's see. Forefoot varus only contributes indirectly to medial tibial stress syndrome. So basically, if you have forefoot varus, then you're going to get compensatory pronation, and then tibial internal rotation increases, and this repetitive torsional stress of the tibia occurs, and traction forces increase along the medial tibia. Hip internal rotation is even less directly a contributing factor, but if you follow down the line, hip internal rotation can eventually lead to MTSS. But if we're going with what's most common, excessive pronation is going to be your best bet. Okay, let's go up. Patient with COPD demonstrates rapid shallow breathing during exercise. Which change would most improve ventilatory efficiency? A, increase exercise intensity. B, encourage slower respiratory rate. C, add upper extremity resistance. Or D, increase tidal volume through pacing. Okay, got a couple people answering. Read it one more time. A patient with COPD demonstrates rapid shallow breathing during exercise. Which change would most improve ventilatory efficiency? A, increase exercise intensity because of the masses, the two. B, encourage slower respiratory rate. Add upper extremity resistance. Or D, increase tidal volume through pacing. So let's go. So D is the answer because increasing tidal volume through pacing, you're pacing your breathing, right? So that means I'm going to take X number of seconds to breathe in and X number of seconds to breathe out, which is what we use to describe pursed lip breathing, right? So we're going to get that improved alveolar ventilation, and it's going to reduce dead space ventilation, right? So A is actually going to worsen dyspnea. We know that. C increases ventilatory demand because upper extremity tends to increase heart rate more, and so we have greater oxygen demand with upper extremity activity. The reason B is not the answer is because just decreasing your respiratory rate it's not the same as pacing it, right? So you're just trying to breathe slower. Pacing your breathing through intentional, like structured counting of like take a 4-second breath in, try to fill up your lungs all the way, and take a 4-second breath out, or 8 seconds, or whatever you want to do, right? So that way you're actually working on ventilation and not just slowing down your breathing. That's why not B. Number 11. A patient following left CVA demonstrates non-fluent speech, intact comprehension, and frustration with attempts to speak. Which area of the brain is most likely affected? A. Wernicke's area, B. Broca's area, C. The arcuate fasciculus, or D. The right temporal lobe. B. Good. Okay. Let's go ahead. You're absolutely right, group. So the reason being, and this is something that you might run into on your exam, where instead of saying Wernicke's aphasia or Broca's aphasia, instead of saying expressive or receptive aphasia, they're going to call it non-fluent or fluent aphasia. And if you haven't heard those terms before, it could throw you off like it did me when I was taking practice tests. But if it says non-fluent speech or non-fluent aphasia, that means that they're not speaking fluently, that they're having a hard time producing their speech, right? Which is indicative of Broca's. The reason fluent aphasia is considered Wernicke's is because they still speak fluently, they just don't make any sense, but they can create all sorts of, broke people can't express themselves probably. Wernicke's area is word salad. Yeah, exactly right. So fluent aphasia, they can produce language just fine. It just is nonsensical, right? C, this would produce conduction aphasia, so being able to repeat things would be impaired. And then the right temporal lobe is not language dominant, right? At least in the vast majority of people. What is interesting, if you didn't know this, is left-handed people tend to have more equal representation of Wernicke's and Broca's areas bilaterally compared to. Yes, you're absolutely right. Sorry, that threw me off. C, can't articulate the words or fine or like stumble over. Yeah, exactly. Um, yeah, people with left hands, or people with left hands, people that are left-handed tend to have more equal representation from right side and left side in terms of the language centers in their brains. And so left-handed people who get left-sided strokes can still use the right side of their brain to compensate for that because they have more equal representation of language centers, whereas right-handed people don't, which I think is wildly fascinating. 12. A patient undergoing phase 2 cardiac rehab demonstrates the following during treadmill walking: gradual onset of chest tightness, ST segment depression on telemetry, and symptoms resolve with rest. What is the most appropriate clinical interpretation? A, this is a normal exercise response. B, ventricular hypertrophy. C, myocardial ischemia. Or D, pulmonary limitation. Read that again. A patient undergoing phase 2 cardiac rehab demonstrates the following during treadmill walking: gradual onset chest tightness, ST segment depression on telemetry, and symptoms resolve with rest. What is the most appropriate clinical interpretation? A, normal exercise response. B, ventricular hypertrophy. C, myocardial ischemia. Or D, pulmonary limitation. Looks like the ST depression be the main giveaway. I certainly think so, right? Um, I certainly think so. And another thing that's good is that, or that would point you in that direction, is that it's like symptoms resolve with rest, right? So we're talking about ischemia. We're not talking about an infarction, right? So you get classic ischemic signs, so that ST segment depression, you get gradual onset of chest tightness, and then it's exercise induced and it's reversible, meaning when they sit and rest, it goes away. A is wrong because this is not a normal response to exercise. If you've ever exercised and not had cardiac ischemia, you know why this is not normal. B is going to show voltage changes. Ventricular hypertrophy will show voltage changes on EKG or telemetry and not ST depression. And then pulmonary limitation doesn't cause ECG changes. Right? So yeah, but Gentry, I agree. If you see that ST depression, then you know that something myocardial is going on. Something like some ischemia is going on. in a test question at least. Number 13, a patient with a lateral ankle sprain has difficulty with push-off during gait. Which muscle is most likely inhibited? A. Tibialis anterior, B. Peroneus longus, C. Gastrocnemius, or D. Tibialis posterior. Give you guys some time to answer. Don't think too hard about this one. Okay, let's go over the answer. C. Gastrocnemius. Okay, so gastroc is going to be critical for push-off and terminal stance. Know that this is not saying, just know that this is not saying that gastroc was injured during the lateral ankle sprain necessarily, right? It's just that they have difficulty with push-off after a lateral ankle sprain. So it could just be that a significant contraction of gastroc just exacerbates pain because of the lateral ankle sprain, right? Tibialis posterior wouldn't be affected in lateral ankle sprain, right? Peroneus longus might, but it's not our predominating plantar flexor, especially with push-off. And tib anterior wouldn't be affected. It wouldn't be affected during push-off at the very least. So that's why gastroc is the answer. Number 14, a patient with a stroke demonstrates dysmetria of the right upper extremity, intention tremor, and decomposition of movement. Where is the lesion most likely located? A, right cerebellar hemisphere, B, left cerebellar hemisphere, C, brainstem, or D, basal ganglia. Peroneus longus is an everter. Is that what you're asking? Yeah, Peroneus longus is an everter, so it's possible with a lateral ankle sprain that you may have damaged the peroneus or fibularis longus and brevis tendons. So they might be painful, but because they aren't, like I said, they're not the predominating plantar flexors with push-off, so that's why. A patient, let me read this one more time. A patient with a stroke demonstrates dysmetria of the right upper extremity, intention tremor, and decomposition of movement. Where is the lesion most likely located? A, right cerebellar hemisphere, B, left cerebellar hemisphere, C, brainstem, or D, basal ganglia. Okay. All right. Let's go over it. A. So your cerebellum controls ipsilateral coordination. So Gentry, you're absolutely right. Cerebellar lesions or cerebellar strokes result in ipsilateral deficits, right? So we're seeing that right limb ataxia with the dysmetria and then tension tremor and the decomposition of movement, right? B, wrong side, because if it was left cerebellar hemisphere, all of this would be on the left. C would involve cranial nerves, not dysmetria and intention tremor. And then D would result in rigidity and bradykinesia and not ataxia. Yeah. Okay, let's move on to 15. A patient with interstitial lung disease presents with marked desaturation during minimal exertion, normal resting SpO2, and severe exertional dyspnea. Which training modification is most appropriate? A, high intensity interval training, B, continuous moderate exercise, C, interval training with frequent rest, or D, resistance training only. Gentry on it quick tonight. She's answering before I even get done reading. Okay, we've got a few more people that joined the live, so I'll give a little bit more time, see if any of them want to answer. I'll read it one more time while we wait. A patient with interstitial lung disease presents with marked desaturation during minimal exertion, normal resting SpO2, and severe exertional dyspnea. Which training modification is most appropriate? A, high-intensity interval training, B, continuous moderate exercise, C, interval training with frequent rest, or D, resistance training only. Okay, we'll go ahead, go over the answer. Make sure there's not more below. All right, the answer is in fact C, because it allows for periods of work without risking severe hypoxemia. And so this is going to create the best, this is going to be the best strategy for tolerance, building up their tolerance to exercise. A is unsafe, right, because they have severe exertional dyspnea with minimal exertion. B is going to worsen desaturation because if you just have them continuously do exercise, even if it's moderate, and moderate is still an intense exercise, right? It's going to worsen their SATs. And then D avoids aerobic training entirely, and that's what they need based on what their problems are. And so that would not be functional, right? Number 16. How did Mark steal my badge and he just joined? I don't know. You're all about that. You are all about that badge that is meaningless because it doesn't get you. I mean, I guess it gets you to be my number one fan, which is nice for me, but the patient has neck pain with cervical rotation and extension that reproduces numbness in the thumb. Which cervical root is most likely involved? A, C6, B, C8, C, C5, or D, C7? Read that one more time. A patient has neck pain with cervical rotation and extension that reproduces numbness in the thumb. Which cervical root is most likely involved? A, C6, B, C8, C, C5, or D, C7? Okay, getting some more people participating. Awesome. It's good to have you in here. Let's see how many people I think it's in so far. Just about 4. Let's wait just a hair longer, see if I'll get anyone else to respond. These are some of my favorite questions because I love the spinal cord. And so knowing myotomal and dermatomal distributions is super easy if, well, these questions are super easy if you know your dermatomal and myotomal distributions, right? So let's go over the answer. The answer is A, C6, right? C6 dermatome supplies sensation to the thumb. So C5 is going down the lateral arm, right? Let me show you this way. C6 is going to be lateral forearm and thumb. C7 is middle finger. C8 is pinky and medial palm, right? Okay, moving on to another neuro question. Patient with a TBI is able to ambulate independently in familiar environments, but demonstrates poor judgment and requires supervision in community settings. What level of assistance is most appropriate? A, independent, B, modified independent, C, supervision, or D, contact guard assist? Give you guys some time to answer. I'll read it one more time. A patient, with TBI is able to ambulate independently in familiar environments, but demonstrates poor judgment and requires supervision in community settings. What level of assistance is most appropriate? A, independent, B, modified independent, C, supervision, or D, contact guard assist? Many of you answered. About a fourth or so. Give a little bit longer. Okay. All right. So the answer is C, supervision. Physically, they are independent, but their cognitive and judgment deficits just require oversight, right? We don't want them to do something unsafe. Even though they're physically independent, we don't want them to do something unsafe because of their impaired judgment and cognition. So A is unsafe, right? I would not be like, this person is independent in performing their ADLs. B, still requires a safety judgment, right? So like just because I gave them a cane, it doesn't mean that they suddenly have good judgment. And then D, this person doesn't need any physical assistance. There's no reason I have to have my hands on this patient. How many questions do I have for today? I've got 24, so we got 7 left, and then we'll be done. We're kind of cruising through right now. 18. A patient with orthostatic hypotension experiences dizziness when moving from supine to standing. Which intervention is most appropriate initially? A. Rapid position changes. B. Elastic compression garments. C. Trendelenburg positioning. Or D. Valsalva maneuver. Got 1, 2 answers. 3. Just a little bit longer. While we're waiting, I'm going to go fill up my water again. Yeah, Maggie. I've got my microphone on right now so they can hear you. But go ahead. If you really want to say something, say it now. Okay. B. You guys are absolutely right. So compression garments are going to improve venous return, right? And it's honestly a pretty first-line conservative intervention. The reason none of the rest of these are good is because A is going to worsen their symptoms, right? And so you're not going to be able to do anything functional with them as a physical therapist. C, again, this might help with improving their hypotension if it's been exacerbated, but you're not going to be able to do a lot of functional stuff from a Trendelenburg position. And then D is actually going to decrease their venous return, which again is going to worsen their orthostatic hypotension. So putting on compression garments and then getting them up and seeing if it helps, then you can probably do something functional like walking or strength training or something like that, right? Moving on to number 19. A patient presents with anterior knee pain, ascending stairs. Which muscle weakness most likely contributes? A. Vastus medialis, B. Gluteus medius, C. Hamstrings, or D. Adductors. Give you guys a little longer. Okay, let's go over it. The answer is B. And the reason being is that presumably if you have a weak glute med, you're going to get more femoral internal rotation and adduction, which means that your patella is going to most likely want to track laterally, right? So you're going to get increased patellofemoral stress from weak glute meds because you're going into essentially valgus in a knee flexed position, right? And so vastus medialis, I know why you think that because we all learn like strengthening VMO helps prevent patellofemoral pain, but tell me, this is always one thing I want to say. How are you going to isolate VMO if you're like trying to strength train to prevent patellofemoral pain syndrome or lateral patellar tracking? How are you going to isolate VMO to make sure that patella doesn't want to track laterally? And I know that there are some tricks that people say, like maybe doing long arc quads with ball squeezes, but that's not isolating VMO. In fact, they've done EMG studies with that, and it's showing that VMO isn't used for adduction, so adding an isometric adduction isn't going to increase VMO. You could put E-stim on the vastus medialis, but again, once they get off of that E-stim, how do you know that you're training VMO to pull harder than vastus lateralis on that kneecap, right? And so if we give good glute med strength, then they'll have improved knee positioning and stability when they're ascending stairs, which will decrease that lateral patellar tracking and decrease that anterior pain. Does that make sense? You guys believe me, or do you think I'm full of crap? Is there any questions about that one? Or you all just, because that one was, I mean, everyone that answered said A. And so I just want to make sure that you guys feel like what I'm saying makes sense and you can understand why the answer is what I said. Okay. I don't want you guys to be like, this guy's full of garbage. And if you do think that, let's have a discussion about it, because maybe you're right. But in this case, I'm telling you, on the boards, this is going to be your answer with lateral patellar tracking, glute med strengthening, and maybe IT band or lateral retinaculum. IT band rolling, stretching, and lateral retinaculum mobilizations to stretch it. But number 20, a patient with multiple sclerosis reports increased fatigue and perspiration, blurred vision, and worsening balance after exercising. What is the most appropriate modification? A, switch to strength training only. B, incorporate active cooling strategies. C, shorten session duration only. Or D, increased rest breaks between sets. Give you guys some time to answer that one. Go. I'll read it one more time. A patient with multiple sclerosis reports increased fatigue and perspiration, blurred vision, and worsening balance after exercise. What is the most appropriate modification? A, switch to strength training only. B, incorporate active cooling strategies. C, shorten session duration only. Or D, increase rest breaks between sets. Several of you have answered, so we'll go ahead and go over the correct answer. The correct answer is B, because what we are describing in the stem of this question is Uthoff's phenomenon, right? So heat slowing neural conduction. Cooling improves function. So D, increasing rest breaks, would be helpful, but it's not addressing the cause of the Uthoff's phenomenon symptoms. So it's cute. So one thing that tells me she's overheating, right, is that she's sweating, right? The other thing that's happening is blurred vision, which doesn't happen with just fatigue, right? I'm getting off. If I get another wrong TBH, don't need my confidence gauge. Okay, that's fine. That's fine, user. So just know, perspiration suggests that she's warm. Blurred vision is a worsening neurologic symptom that happens with Uthoff's phenomenon, not just fatigue. And then worsening balance is kind of one of those that's like in between. That could be a result of fatigue, or it could be a result of Uthoff's phenomenon. A is not going to prevent the heat response. C is an incomplete solution, and D is helpful but doesn't address the cause of the worsening neurologic symptoms. Okay. 21. A patient with acute exacerbation of heart failure presents with crackles bilaterally, orthopnea, and weight gain of 6 pounds in 1 week. What is the primary physiological problem? A, decreased preload. B, fluid volume overload. C, reduced pulmonary compliance. Or D, decreased systemic vascular resistance. Take some time. Read it one more time. A patient with acute exacerbation of heart failure presents with crackles bilaterally, orthopnea, and weight gain of 6 pounds in 1 week. What is the primary physiological problem? A, decreased preload. B, fluid volume overload. C, reduced pulmonary compliance. Or D, decreased systemic vascular resistance. Hold on one sec. I'm getting my puzzle piece that I got to put in place to stay on. Okay. What happened? My puzzle piece. Okay. You guys can still see and hear me. We'll just go ahead and go over the answer choice. or the correct answer. The correct answer is B, fluid volume overload. So crackles plus orthopnea plus weight gain are hallmark signs of congestion. A would be the opposite of what is true, right? So decreased preload is usually not what happens in sorry, this is not going through for me. Decreased preload is usually the opposite of what happens in acute exacerbation of heart failure, right? Fluid volume overload, that was the answer. C, reduced pulmonary compliance as a secondary issue in this case. And then D, decreased systemic vascular resistance is not a primary problem in acute. Otherwise, I'm going to have to get through these next 3 questions in just a few minutes. Okay, cool. Any questions about that one? Because there was a couple that were not sure about that. If not, we'll just go ahead and move on. Number 22, following a TKA, which goal is most critical in the first 2 weeks? A, full strength, B, normal gait speed, C, knee extension range of motion, or D, stair negotiation. Also, user, you got that last one right, so way to go. You don't have to hop off, which is good. And then we just got 2 questions left after this, guys. Okay, let's go ahead and go over it. You guys were not tripped up at all by that one, which is great. Obviously, in the first 2 weeks, we don't need to get them back to normal gait speed. We don't need them to be able to negotiate stairs necessarily. That might be something we have to teach them, but only if that's something they're going to regularly engage with at home. But knee extension range of motion in the first 2 weeks is absolutely critical. We need them to get that range of motion back as quickly as possible, so that way they don't end up with prolonged scarring, preventing extension range of motion and joint contractures. So. Number 23, a patient with a chronic stroke demonstrates increased tone in his elbow flexors that limits active reach. Which intervention best targets the underlying impairment? A, passive stretching, B, weight bearing through the upper extremity, C, strengthening elbow flexors, or D, task-specific reaching without tone management. Read it one more time for you guys. A patient with chronic stroke demonstrates increased tone in the elbow flexors that limits active reach. Which intervention best targets the underlying impairment? A, passive stretching, B, weight bearing through the upper extremity, C, strengthening elbow flexors, or D, task-specific reaching without tone management. Many of you have answered, so we'll go ahead. The answer is B. The idea behind weight bearing is that it's going to inhibit the tone and facilitate co-contraction. So we're going to get them out of that elbow flexed position, get the triceps turning on a little bit more, which can also help inhibit tone in the biceps, right? It's functional and it's evidence-based, right? So A might, a lot of people think stretch to help alleviate tone, but it's not going to have much in the way of long-term effects in terms of trying to move on to something else in your treatment that allows you to making reaching or something more functional. Strengthening is actually going to worsen tone, and D is going to be largely ineffective without tone control, right? So this would be a good thing, like have them do some weight bearing stuff through the upper extremity to help manage and decrease that tone, and then after you've done that, move into some task specific reaching, maybe some like constraint induced movement therapy stuff, so that way they actually have some extra range of motion to capitalize on because their tone isn't limiting that range of motion anymore. Okay, And the last one for my buddy user before your boards this week. So, a patient in the ICU is mechanically ventilated and demonstrates decreased chest wall excursion and secretion retention. Which intervention is most appropriate? A, early mobilization and positioning. B, incentive spirometry. C, maximal inspiratory pressure training. Or D, aerobic conditioning. A patient in the ICU is mechanically ventilated and demonstrates decreased chest wall excursion and secretion retention. Which intervention is most appropriate? A, early mobilization and positioning. B, incentive spirometry. C, maximal inspiratory pressure training. Or D, aerobic conditioning. Okay. Many of you have answered. Oops. And so let's go ahead and go over the correct answer. So the correct answer is A, early mobilization and positioning. So getting them up and focusing on proper positioning to mobilize secretions is going to help improve their ventilation. It's going to aid in secretion clearance, right? Because getting them up and moving and breathing more, it's going to help get some air behind the secretions so that way they can cough them out. And there's really good evidence in ICU research that this is effective. B, the patient can't use this because they're mechanically ventilated, right? Past screen coming soon. I thought, B, because patient is mechanically ventilated. So maximal inspiratory pressure training is not typically utilized in the acute stage when the patient is ventilated, because this is still something that they would have to do actively. And when they're mechanically ventilated, it's breathing for them, right? And then D is inappropriate at this stage. We don't want to start pushing aerobic intensity or aerobic conditioning this early on. But yep, that is it, guys. That's all 24 questions for tonight. I will download and post this live to my YouTube channel probably tomorrow when I've got some time. And then I'll go ahead and get some questions ready for next week. Gentry, you are the next one I know that has the test coming up. If anyone else is taking the boards in April, is there any particular topic that you want me to focus more heavily on next week? I probably won't prepare 24 questions. I may just prepare 20, since we're not trying to like do en masse, since the next boards exam is until April. But Gentry, do you have anything in particular that you want me to focus on to just help you practice with, or Lori, or Sandwich? If not, the questions I have found, I'll definitely binge watch your videos. Okay, Alison, I do this every Sunday. I was going to take a couple weeks off, but because I did my first PET and scored low on non-systems and interventions. Okay, cool. Thank you all, and thank you, Austin. Hi, my boards aren't until next year. That's fine, Sandwich. That's good. You got a lot of time to prep. User, thank you, buddy. Good luck this week. I'll be thinking about you on Tuesday, and don't sweat it. Tomorrow, take the day off. Just do something relaxing, and you'll do fine. You'll do fine. Gentry, I'll focus next week on some non-systems. Can you help me, though, a little bit? Would it be more helpful to focus more on research in the non-system stuff? Would it be more helpful? Okay, we can do some more cardiopulm. Would it be helpful to focus more on like ethics and standards? Was there something in particular in non-systems that you felt like was troublesome? And then we can go over some interventions as well. I'll try to do some more PT responsibilities and ethics standards. Okay, cool. That's what I'll try to focus on next week. And then next week, we'll revisit this and see what you guys want to do next time. But yeah, Gentry, hope your Pete went well. Everyone else, if you want to join in this regularly, I do this every Sunday night. There will be a time in the next couple of weeks where I'll probably take a couple weeks off just to create more content, more questions and things like that. But otherwise, yeah, you guys have a great night. Have a great snow day tomorrow if you get a snow day. And be safe. I'll see you guys next week.